Welcome back, everybody. And we're going to move to our second session, in which we're going to talk about long-acting injectable PrEP. We'll have in this session 4 talks. The first about pharmacokinetics of long-acting CAB by Marta Bofito, then an overview of clinical data by Mina Hosseinipour. Then Dr. Landowitz is going to talk about resistance and breakthrough infections. And then Linda Gale Becker is going to talk about what is on the horizon in the PrEP arena. So the first talk on long-acting injectable PrEP will be by Marta Bofito. Marta was trained in Italy, in USA and UK, and she has a special interest in, on pharmacokinetics. She's been doing a lot of work in that area. She's extremely well known in the area of pharmacokinetics and drug-drug interactions. She's a consultant physician, a clinical research lead of the clinical research facilities and HIV service at the Chelsea Westminster Hospital. She's a reader at Imperial College in London. And she runs numerous projects and clinical trials in pharmacokinetics, and she consults on complex pharmacokinetics issues. So whenever you have a really complex problem on pharmacokinetics of drugs and drug-drug interactions, Marta is the person to call. So Marta, the floor is yours.
Hi, everybody. Thank you for the kind invitation to talk about the pharmacokinetics of long-acting cabotegravir. These are my disclosures. So what are we going to talk about today? We're going to look at what it means having to deal with a long-acting drug, and why we should prescribe long-acting drugs, and whether the concentrations are the same for everybody, whether we should worry about the pharmacokinetic tail, and then we're going to briefly look at drug-drug interactions involving long-acting drugs. So a long-acting drug is a drug that is slowly absorbed and slowly excreted, and it persists in the circulation and tissues and is effective over a long period of time. And the prerequisite of a long-acting drug is that it is administered less frequently. Once a week, once a month, every other month, every 6 months, or even more than 6 months. And interestingly and importantly, it provides increased choice, increased convenience and health privacy, and it simplifies adherence. And it reduces the amount of the active administered drug sometimes. This slide shows the concentrations of a long-acting drug compared to what happens to the concentrations of a orally daily administered drug. You can see that we don't really change the main pharmacokinetic concepts. We need to achieve concentrations that are above the minimum effective concentrations and are effective for prevention. We need to make sure that the maximum concentrations is not above the toxicity threshold. And you can see that there is a clear effective range of concentrations. And when I say effective in this context, it's obviously effective for HIV prevention. So what about cabotegravir long-acting? This slide shows the history of its development. It was obviously studied first preclinically in primates, and it showed that it protects macaques from intrarectal sieve infection. Preclinical studies are followed by phase 1 studies. Phase 1 study shows that the concentrations achieved in plasma persist for prolonged periods of times, and also tissue concentrations were measured in people without HIV. Phase 2 studies were very important to establish the dose and the dose frequency for cabotegravir PrEP. Today, cabotegravir PrEP is used every other month. And then large phase 3 studies were presented over the past few months and showed that cabotegravir was able to prevent HIV infection. The HPTN-083 and HPTN-084 studies provide very solid pharmacokinetic data. The HIV incidence rate in 083 was remarkably lower than the incidence rate for Truvada and FTC, for tenofovir and FTC taken orally. Interestingly, however, there were 4 infections that occurred despite continuous cabotegravir long-acting treatment and despite the achievement of protective drug concentrations. Was this because there was not enough drug in compartments? Or it's because of the viral load in these people was so high that the concentrations achieved weren't enough to prevent the infection? Hopefully, we'll have these answers soon. There were 1 to 2 infections in the breakthrough infection in the HPTN-084, which was conducted globally in women to prevent HIV infection. HPTN-083 also looked at transgender women, and the ethnicity distribution in both studies was very wide. So both studies, I believe, are very informative. So let's talk a little bit about cabotegravir population PK. Population PK is useful to characterize the pharmacokinetics of the drug and determine factors that influence parameter variability and drug exposure. It can also help to optimize dosing strategies. Interestingly, there are some factors that influence the pharmacokinetic parameters of cabotegravir long-acting, and these are gender and BMI. So a typical female has a slower absorption rate and a longer persistence of cabotegravir in the body. And also, while accounting for gender, a larger BMI causes a modest decrease in absorption rate compared with smaller BMI. However, the magnitude of change in absorption of cabotegravir did not alter its trough concentrations to a clinically significant decrease. So that is why these factors don't affect cabotegravir too much, and cabotegravir C-trough remain appropriate for efficacy in preventing HIV infection. They achieve level well above the effective established targets. However, there are still some outstanding issues when we plan to use cabotegravir long-acting. We need data in girls younger than 18 years. We need data during pregnancy and breastfeeding. We need to know whether cabotegravir is present in the milk and what are the concentrations of cabotegravir in the milk. There are still some real-world implementation issues and strategies to optimize adherence to appointments need to be implemented. And also, there are concerns about the pharmacokinetic tail. Briefly, what do we mean for pharmacokinetic tail? So these are the concentrations of cabotegravir that would be achieved if someone who is administered cabotegravir for PrEP doesn't show up at his next dose appointment. These concentrations will inevitably achieve suboptimal levels. And we know from data in primates that if this is the case, there is a risk for resistance development. These graphs show that when the concentrations of cabotegravir decrease, these are indicated in pink, the viral replication restarts, this is indicated in blue, and when the viral replication restarts, mutations that confer resistance to the integrase inhibitors class are developed. Therefore, it is important to introduce the use of cabotegravir long-acting as a strategy and introduce the concept of oral bridging strategies so that if someone is not able to show up at the next appointment for his injections, we can bridge with oral drug to ensure that these low and risky concentrations are not achieved. Briefly, what about drug-drug interactions for long-acting drugs? Because these drugs are not administered orally, the likelihood for drug-drug interactions to occur at the level of the gastrointestinal tract is 0, which is very good news because we will have to face a lower risk for drug-drug interactions in general. However, let's not forget that there still could be drug-drug interactions that are clinically significant. So if we co-administer strong UGT1A1, which is the main metabolic pathway for cabotegravir metabolism, induces, like rifampicin, the risk for cabotegravir concentrations to be remarkably decreased and ineffective is there. In conclusion, we know that people prefer long-acting in treatment trials. What about prevention trials? You can see here the results from patient-reported outcomes from HPTN 077. And you can see how many people actually expressed the wish to be on cabotegravir long-acting to prevent HIV infection. So what are the take-home message? Well, there are definitely exciting developments with injectables and implants and other long-acting formulation. We need to learn about the PK tail. We need to learn about different population exposures, bridging strategies. We need to be very comfortable with all of that to advise our patients on what is best to do while they are on cabotegravir long-acting PrEP. Obviously, the issue about drug-drug interactions remains, but we are avoiding all of the gastrointestinal tract drug-drug interactions. And we're up for implementation challenges, and obviously we need data during pregnancy. Thank you very much for your attention.
Thank you, Marta, for a very, very nice, interesting presentation as always. And so our next talk will be by Mina of Singapore. She's going to give us an overview of clinical data. Mina, she is a professor of medicine. She has been based in Malawi for the past 10 years, where she directs the UNC, the University of North Carolina Project Malawi. She's in fact the co-principal investigator of the UNC Global Clinical Trials Unit. She has done research in numerous areas in HIV, from treatment, prevention, complications, opportunistic infections. But relevant to her talk today, she's a co-chair of the HPTN 084 study, which evaluates cabotegravir long-acting for HIV prevention in women. So, Mina, the floor is yours.
Thank you for that kind introduction. I'm pleased to talk to you today about long-acting antiretroviral therapy prevention focused on long-acting injectable PrEP and review the current clinical evidence. As we have heard today, many clinical trials and emerging real-world data over the last decade has demonstrated that oral antiretroviral therapy as PrEP, can reduce HIV acquisition if taken as prescribed. Oral PrEP success relies on regular adherence to the oral tablets, particularly for women for whom there is less forgiveness in missed doses. Despite expanding access to oral PrEP, individuals at risk can experience significant barriers to daily pill taking, including stigma, judgment, and sometimes the threat of violence by family members, partners, or the community. Novel long-acting products like cabotegravir, administered less frequently, may simplify PrEP use and provide a discrete strategy for PrEP. Injectable PrEP has several advantages, in addition to being a preferred stated method by the populations who desire to use a PrEP product. Every 2 months injections can directly tackle adherence issues, and it is very discreet. But it can't be removed once injected, so there could be potential for prolonged side effects. Also, there is a long pharmacologic tail after the last injection, which may have resistance implications in the event that one becomes HIV infected. And more recently, current testing algorithms may not detect breakthrough infections as effectively, and Dr. Landowitz will be discussing that after me. The clinical data to date stems from 2 clinical trials that I will now review. HPTN 083 and 084 trials have recently reported their primary results. These companion studies have similar objectives, designs, but targeted different risk groups for HIV. The primary objective of both studies was to evaluate the relative efficacy and safety of cabotegravir injection versus oral TDF-FTC in preventing the sexual acquisition of HIV. It's important to note that both studies had active comparators. To characterize some of the similarities and differences of the study, I've included this side-by-side comparison. Both studies used injectable cabotegravir and oral TDF-FTC. HPTN 083 targeted and enrolled 4,570 cisgender and transgender women who have sex with men, while HPTN 084 targeted 3,224 cisgender women. HPTN 083 had sites across 4 continents, while HPTN 084 targeted only sub-Saharan African sites. HPTN 083 was out of the gate sooner in December 2016, and 084 started in November 2017. 083 had a non-inferior design, essentially to look at if they were the same, and HPTN 084 had a superiority design to see if cabotegravir injectable was better than TDF-FTC. Both studies targeted and enrolled groups deemed at highest risk for HIV infection based on local epidemiology. HPTN 083 included those who had any reported non-condom receptive anal intercourse, reported greater than 5 partners, stimulant drug use, incident rectal or urethral STI in the past 6 months, and in the United States, having a SexPro score less than or equal 16. This study purposely had targets to enroll 50% of its population under age 30, include greater than 10% transgender women, and 50% of the US enrollment should be Black. And notably, all of these targets were met by HPTN 083. In HPTN 084, sexually active women aged 18 plus at risk of HIV living in sub-Saharan Africa were enrolled. Countries involved included South Africa, Botswana, Eswatini, Zimbabwe, Malawi, Kenya, and Uganda. HPTN 084 used the modified voice risk score to identify participants likely to be at substantial risk for HIV and PrEP eligible in accordance with country and WHO guidelines. The score is based on a composite of characteristics related to age, partner characteristics, and alcohol use. The cutoff was increased from 3 to 5 in version 2 of the protocol in order to ensure the highest risk groups were enrolled. In both studies, participants were excluded if they had any medical or other contraindications to either study product, including hepatic or renal insufficiency. Also, if they had any history of seizures. This is the study design of HPTN 084. Participants were randomized 1-to-1 to one of the study arms. In the Truvada arm, participants received active Truvada and placebos for cabotegravir, and in the cabotegravir arm, participants received active cabotegravir and tenofovir FTC placebo. There was a 5-week oral lead-in period where oral tablets were taken to ensure tolerance of the product before injection. After the lead-in, participants received injections of cabotegravir or placebo, and they received a loading dose at 4 weeks and then injections every 8 weeks thereafter. Participants who discontinued injections for safety or other reasons were offered open label TDF-FTC for 48 weeks after discontinuation of study injections. This was to address the hypothetical risk of resistance in emergent infections that might occur during the pharmacokinetic tail. Pregnant women who were offered open label TDF-FTC throughout pregnancy and breastfeeding, and HIV and pregnancy testing were done at all of the visits where study products were administered. HPTN-083 had the same general design, including the step 1 oral lead-in phase, the step 2 injection phase, according to the same dosage and same frequency of injections, and then had the open label oral Truvada to cover the tail. How well did these products work? Both studies had the same data safety and monitoring board and underwent review at 6 monthly intervals. And notably, both studies were stopped early for demonstrated efficacy. In HPTN-083, a total of 52 infections were noted, 13 in the cabotegravir arm and 39 in the TDF-FTC arm. The incidence in the cabotegravir arm was 0.41 per 100 person years, and the rate in the TDF-FTC arm was 1.22. This corresponds to a hazard ratio of 0.34, representing a 66% reduction of HIV acquisition favoring cabotegravir. And this actually met the definition for superiority, even though the study was designed for non-inferiority. Here we see the cumulative incidence of HIV acquisition over time, highlighting again the 66% reduction of HIV acquisition in the cabotegravir arm. In HPTN-084, 40 confirmed HIV infections were noted. The overall HIV incidence among all study participants was 1%, suggesting that both products were highly effective in preventing HIV in this at-risk population. 4 infections were detected in the cabotegravir arm, which is equivalent to an incidence of 0.2%, and 36 infections were detected in participants assigned to the TDF-FTC arm, which is an incidence of 1.86%. In reviewing the cumulative incidence of HIV over time since enrollment, we see that women in the cabotegravir arm had an 89% lower risk of HIV infection compared to TDF-FTC. Most likely, this was due to an adherence advantage conferred by 8 weekly injections. In summary, both studies showed superiority of cabotegravir over daily oral TDF-FTC. Now let's discuss adherence. For both studies, a subset of participants receiving TDF-FTC had sampling to measure tenofovir levels to help understand oral adherence to the study product and how it might inform the efficacy results. This slide demonstrates the adherence levels to oral product in HPTN-083. In green colors are the proportion of patients that relate to 4 to 7 or 7 doses per week. We can consider this good adherence. The red highlights those with no detectable levels, and this would be non-adherence, and the yellow is in between. Overall, there was generally high adherence in this population, but over time, one sees the proportion that is green gradually decrease, while the portion in red and yellow increases somewhat, suggesting that adherence challenges increased over time. However, note this is quite high adherence for HPTN-083. In HPTN-084, a similar analysis was conducted. Overall, 62% of the participants receiving TDF-FTC had detectable concentrations of tenofovir, and 46% had levels consistent with daily use. Note, this is somewhat lower than the HPTN-083 population. we see that initially at week 4, the levels were higher, and gradually over 1 year, we see that just over half have detectable levels, suggesting again that pill taking was particularly challenging for this population. Also, these levels likely demonstrate why the results are different for cabotegravir versus Truvada. Here we see the injection coverage for HPTN-084. This shows that essentially coverage was high and maintained above 90%, essentially for the entire period of the study, and emphasizing the adherence advantage that long-acting injections can provide. Let's now shift to safety. In HPTN-083, grade 2 or greater adverse events were generally balanced. Although highlighted here in the red boxes, we can see that decreased creatinine clearance was more common in the TDF-FTC arm, and nasopharyngitis, increased blood glucose, and pyrexia were more common in the cabotegravir arm. In HPTN-084, we actually see that adverse events at grade 2 plus or higher, there was actually no differences in the arms. For both studies, injection site reactions varied by arm, and more participants in the cabotegravir arm experienced this adverse effect. Here, for HPTN-083, we see that just over 80% of the participants reported injection site reactions in the cabotegravir arm, compared with 31.2% in the TDF-FTC arm. The proportion reporting injection site reactions did reduce over time with subsequent injections. And this study had 2.2% of cabotegravir participants permanently discontinue cabotegravir due to injection site reactions, and this correlated with the severity of the reaction. In contrast, in HPTN-084, a similar pattern held, that injection site reactions were more common in the cabotegravir arm, but the magnitude was dramatically less. 32% of participants in the cabotegravir arm reported any injection site reaction over time, compared to 9% in the TDF-FTC arm. This was highest at the initial visit and essentially became negligible over time. Most injection site reactions were mild and occurred within the first 1 to 2 days of injection. And for HPTN-084, there were no discontinuations due to this adverse effect. Weight gain has been an interesting area for exploration related to integrase inhibitors, tenofovir and TAF. So we evaluated weight change. Here we can see there is a small immediate weight increase in the cabotegravir arm, approximately 0.4 kgs. But then there is steady linear increase over time, such that when you evaluate at later time points, the amount of weight gain is actually similar over time. A similar trend is seen in HPTN-083, where an initial weight gain was noted in the cabotegravir arm through week 40, but then from week 40 to 105, the weight gains were similar, such that at the end of the evaluation, the weight gains are not significantly different. I also will report on HPTN-084 pregnancy issues. We observed 50 pregnancies during the study, and there was no significant difference by pregnancy incidence by arm. It was quite low. There was high adherence to the family planning requirements. Of the 50 confirmed pregnancies, 23 are ongoing, and we have outcome data for the remainder. There were 20 live births, 10 in each arm. There were 3 pregnancy losses at 20 to 36 weeks, including 2 cases of intrauterine fetal demise, 1 associated with pregnancy-induced hypertension, and there was also miscarriage at 21 weeks. There were 4 pregnancy losses at less than 20 weeks, and 3 of these were elective terminations. There were no congenital anomalies observed. So in summary, both agents are highly effective in preventing HIV. In HPTN 084, the pooled incidence was essentially 1%. In 083, it was 0.81 per 100 person years. Cabotegravir was superior to daily oral TDF FTC in both studies. There was an 89% lower risk of HIV infection in 084 and 66% lower risk of HIV in 083. Cabotegravir long-acting, given by injection every 8 weeks, likely provided an adherence advantage over the daily oral TDF FTC based on the subset analysis of tenofovir levels. Both products were safe and well tolerated, with few differences in grade 2 or higher adverse events, with the exception of injection site reactions. Injection site reactions were generally mild, associated with pain, and generally occurred at the first injection. Injection site reactions were more commonly reported among men. Initial weight gain was noted for cabotegravir, but similar modest gains in both arms occurred over time, such that at 3 years, similar weight gains had occurred. Cabotegravir is the first safe and effective injectable PrEP agent for cisgender women, men who have sex with men, and transgender women. I'd like to acknowledge the study participants who volunteered their time to this effort. Both studies are supported by the Division of AIDS, the NIAID, and receive funding with ViiV, Bill and Melinda Gates, and generous contribution of study drug by Gilead Sciences. And we acknowledge the incredible teams behind this work that has been done by the 084 and 083 teams. Thank you very much.
Thank you, Mina. Now we move to Dr. Lenovitz, who's going to talk about resistance, breakthrough infections. Dr. Lenovitz is a Harvard person, where he went to medical school, did his residency, became chief resident, then did his fellowship. And through the Harvard CDC Vietnam partnership, he moved to Vietnam for a while, where he co-directed their center. In 2006, he joined UCLA, where he's a professor now. He's been awarded the John Kerry Young Investigator Award from the ACDG. In 2017, he received the American Association of HIV Medicine Research Award. But most importantly for us, for this meeting, Rafi is the guy who led HPTN 083, the one was Mina just mentioned, and the trial that's changing practice of HIV prevention in the world. So, Dr. Lenovitz, the floor is yours.
I'd like to thank the organizers of the conference for the opportunity to present some additional data on long-acting injectable cabotegravir for HIV PrEP, focusing on resistance and breakthrough infections. I think everyone is aware from the prior presentations that this is the study design of both the HPTN 083 and 084 studies, which enrolled participants who were at elevated risk for HIV infection and randomized them at a 1-to-1 ratio in into either a cabotegravir active arm that also administered a TDF-FTC placebo, or a TDF-FTC arm that also administered a cabotegravir placebo. That oral phase followed by in a direct oral injectable comparison was designed to last approximately 3 years, and individuals who stopped cabotegravir injections prematurely received an additional 48 weeks of open label TDF-FTC to provide ongoing PrEP. These were the original pre-specified analyses of the primary endpoint that we presented at the AIDS 2020 conference in July of 2020 from the HPTN-083 study, wherein we found 13 incident HIV infections in the cabotegravir arm for an incidence rate of 0.41 compared to 39 incident infections in the TDF-FDC arm for an incidence rate of 1.22, resulting in a hazard ratio of 0.34 with 95% confidence bounds that clearly excluded the pre-specified non-inferiority margin of 1.23 and the superiority bound of 1.0. As we were doing this primary analysis and subsequent work, we became aware that cabotegravir seemed to have a profound ability to suppress viral replication in the context of both prevalent or baseline and incident HIV infections, delaying diagnostic testing-based identification of those HIV infections by conventional testing algorithms. This was what was pre-specified in the HPTN-083 protocol. On the left side of the slide, you can see what was done at the sites. So all participants at every visit were administered and received a rapid point of care antibody test, as well as a 4th or 5th generation antigen antibody test that was done in a lab-based setting. Participants also received an HIV RNA test that had to be not detectable within 14 days of original trial enrollment. Additional testing that was pre-specified was done retrospectively on stored samples from all participants, and it was performed at the Johns Hopkins laboratory at the HPTN Laboratory Center. These included a 4th generation instrumented antigen antibody HIV test that was an Architect test, a confirmatory or discriminatory test that was a Genius test, an Aptima qualitative RNA test, and back testing using the Aptima qualitative RNA assay until it was negative at least one visit. What we learned because of these prolonged and profound suppression of the existing testing algorithms was a need to do the following additional testing that was added post hoc. In addition to the 4th generation confirmatory or discriminatory and Aptima qualitative testing, we additionally back tested using the Aptima qualitative RNA test all the way to enrollment for the cabotegravir seroconversions and a bookended sandwich approach for the TDF-FDC cases. We did additional quantitative RNA viral load testing as well. At the AIDS 2020 conference, we showed this diagram, which bucketed the, at that point, 13 incident and 2 baseline HIV infections that we found in the HPTN-083 study. We gave them names based on what bucket we thought they fell into in terms of an explanatory model for the breakthrough in the PrEP. Cases A1 and A2, in fact, were not breakthroughs, as retrospective sensitive laboratory testing identified these infections as pre-existing before any PrEP agents were administered. 5B cases, if you will, represented cases that occurred after a prolonged hiatus from last cabotegravir administration. And I would point out that in all 5 of these cases, as you can see represented by the green virus emoji, as well as the black asterisk, that the site-based testing as well as the centralized laboratory testing were identical. There was no delay in detection at the sites compared to the central laboratory testing. For the C cases, these were cases where the virus was first identified in the central laboratory testing during the oral lead-in phase, but in 2 of the cases, C1 and C3, were not detected at the site until active cabotegravir injections had already been administered. And then the D cases represented at the time 5, and I'll tell you more about that number in a moment, cases where breakthrough occurred despite, as far as we could tell, on-time cabotegravir injections. What we learned using the additional retrospective back testing was that we were able to find evidence of HIV infection using this Aptima back testing past the first 1 negative Aptima result on the stored specimens in at least these 2 cases that I've highlighted here in red, D2 and D5. And I'm going to ask you to follow with me in this animation that I've created, where I show you how the green virus emojis in these 2 cases was relocated with the additional back testing. What you'll notice in particular is in the D5 case, now evidence of viral replication was found before any PrEP products were administered, meaning that D5 was appropriately recategorized as A3 rather than D5. So we went from 5 D cases to 4 and from 2 A cases to 3. Using this additional back testing, we also identified an additional baseline case that we've called A4, and bringing the final tally for the original period of pre-specified observation to 12 incident and 4 baseline or prevalent infections in the cabotegravir arm. What this did is it took our initial estimate of the incidence in HIV to include 12 infections in the cabotegravir arm, updated in the orange bar now with red writing on these slides for an updated incidence rate of 0.37 per 100 person years in the cabotegravir arm and a hazard ratio of 0.32 with an unchanged interpretation. In HPTN 084, which was done in cisgender women in sub-Saharan Africa, similar findings have been presented by my colleague Sinead Delaney Moretlowe from the Wits Institute in South Africa. In that study, they found 4 incident HIV infections in the cabotegravir arm and 36 incident infections in the TDF-FTC arm for an incidence rate in the CAB arm of 0.2 per 100 person years and in the TDF-FTC arm 1.86 per 100 person years, also a superiority result. These are the 4 incident infections in the HPTN 084 study. You can see 2 of them represented B-type cases after prolonged hiatus from cabotegravir administration, and 2 D cases which occurred in the context of ongoing cabotegravir injections, although the D1 case, there appears to be some inconsistency in the intervals between some of the injection visits. The pharmacokinetics and resistance from the 084 study are still in progress, and I will not be able to share those with you today, but Dr. Delaney Moretlowe hopes to present those at an upcoming conference in the not too distant future. Again, the B cases are categorized the same way as in the 083, as are the D cases. So what did we learn when we actually looked at the pharmacokinetics and resistance profiles of the 083 seroconverters from the cabotegravir arm? We learned from the group A cases, and if you remember, those are the cases where HIV infection was detected prior to the administration of any PrEP study product. So those who were HIV positive on retrospective testing at study enrollment, this is what we learned. We learned that if you don't diagnose HIV prior to PrEP agent initiation, that is, if you initiate pre-exposure prophylaxis during the acute or eclipse phase of the infection, CAB can make it challenging to diagnose later by virtue of potency of virologic suppression and delays in conventional antibody-based testing. Viral load is lower and it may even be undetectable. Aptima qualitative RNA testing or quantitative RNA testing was the test that was found to detect infection the earliest. And the point of care or rapid and 4th or 5th generation antigen antibody laboratory-based assays were delayed in turning reactive and would sometimes flicker, meaning they would be positive and then negative, so-called reversion. Failure to diagnose HIV infection in this context can lead to continued cabotegravir administration and even continued CAB injections after the oral lead-in. What we found was that with concentrations of cabotegravir that are high, if HIV viremia escapes cabotegravir control, it can be cabotegravir resistant. We had one such case in HPTN 083. But when the virus escapes, that is, you get breakthrough viremia when using cabotegravir during its pharmacokinetic tail, it did not generate cabotegravir resistance. We had one case that interrogated that and resulted in wild type virus. What did we learn from the group B participants in the cabotegravir arm of 083? Remember, those are the participants who had no recent cabotegravir exposure. What we learned is the following. We learned that if you don't take cabotegravir, it doesn't prevent HIV infection. I don't think that's a surprise to anyone. We had 3 participants who acquired HIV during the cabotegravir pharmacokinetic tail, and it did not result in cabotegravir resistance. While this is reassuring, it does not rule out that the cabotegravir pharmacokinetic tail is something that we need to keep an eye on. We need more data. In at least 2 cases, where individuals in the study were provided open label TDF FTC to cover that pharmacokinetic tail, they had no pharmacologic evidence that they took that TDF FTC, and that absence of TDF FTC likely contributed to the susceptibility to HIV acquisition. What did we learn from the Group C cases from the cabotegravir arm of 083? And to remind you, those are the cases who on retrospective testing we identified as having acquired the infection during the oral lead-in period. This is what we learned. If you don't take oral cab, it doesn't prevent HIV infection. We don't know how forgiving oral cabotegravir is to missed doses, certainly not in the same way that we do for TDF FTC-based PrEP. There is a likely time to onset of protection with oral cab that is yet to be defined. And cab delays new HIV detection, that is incident HIV detection, by delaying the reactivity of conventional testing, and cabotegravir injections can inadvertently therefore be provided as monotherapy despite someone actually being HIV infected. As we saw with the A or baseline cases, viremic escape at high cabotegravir concentrations can lead to cabotegravir and other class integrase resistance. So what did we learn from the Group D cases? And if you remember, these are the cases where infection occurred in the setting of on-time and concentration as expected cabotegravir injections. What we learned is that delays in HIV tests occur detecting new infections in all 4 of these cases. As I mentioned, the cabotegravir concentrations in the blood were as expected from previous studies. So therefore, it wasn't unexpectedly low concentrations of cabotegravir that explain the PrEP failures or breakthroughs. If HIV is acquired in the context of high concentrations of cabotegravir and the HIV smolders in the context of that breakthrough, it can lead to cabotegravir and other integrase inhibitor resistance when viremia breaks through and escapes that cabotegravir monotherapy. We do not yet know if that resistance can be avoided by earlier detection of the HIV infection. Let me turn now to the TDF FTC arm of HPTN 083 and try and provide some explanation for why there were 39 incident breakthrough infections in the TDF FTC arm. What we learned is the following. If you don't take TDF FTC, if you don't take it at all, or if you don't take it very frequently, it doesn't work. And in fact, 37 of the 39 incident HIV infections in the TDF FTC arm that we found were attributable to non or extremely poor adherence. One was attributable to the transmission of K65R resistant virus. Interestingly, the M184V mutation was not present, but other non-nucleoside reverse transcriptase inhibitor mutations were present. And one, we don't have either a genotype to help explain it, nor proximate enough measures of longitudinal adherence to fully explicate the reason for that virologic failure. So the key thoughts and take-homes regarding the breakthrough infections and resistance for the infections that occurred in HPTN 083 are here. We found that both cabotegravir long-acting and TDF FTC were both highly effective for HIV prevention, and statistically, cabotegravir long-acting was superior across populations. Concentrations of CAB in the PrEP failures or breakthroughs, at least in HPTN 083, were as expected, but the timing of exposure and infection acquisition being really difficult to establish because of these delays in reactivity of conventional testing complicates correlation of behaviors and other potential factors that could have led to breakthrough or PrEP failure. The overall superiority result of CAB-LA compared to TDF-FTC seems to be driven by better coverage of sex acts with the injectable product compared to a daily oral product. We are now transitioning HPTN 083 and 084 to open label extensions that will be specifically designed to address some ongoing critical questions that will be needed for implementation. First, will the oral lead-in be important for the use of cabotegravir for PrEP? Because it did not seem to sieve out any safety concerns and may in fact represent a period of vulnerability for those challenged by oral PrEP taking, this will be made optional in HPTN 083 and 084 open label extensions. Because of these delays in conventional algorithm reactivity, we are testing the use of sensitive quantitative viral load testing as a primary screen as part of algorithms being performed for all participants at all visits in the ongoing OLE studies. In the setting of cabotegravir LA PrEP use, prompt diagnosis and navigation to ART services with ART initiation rapidly are probably needed to avoid cabotegravir and other integrase resistance, and therefore preserving susceptibility to WHO and other guideline first-line ART therapy. Linda Gale Becker from the Groote Schuur Institute in Cape Town, South Africa, in the follow-up of these data, and we'll be hearing from her again at this conference, really gave us all a challenge. She said that if we can create COVID-19 vaccines in a year, can we challenge the global community to make better diagnostics that will help us identify these infections that seem to be obfuscated and obscured by conventional testing algorithms by the time CAB is available? And I would extend that further and say that these increased sensitivity modalities of testing won't just be applicable to cabotegravir, but to other future long-acting PrEP agents as well. I'd like to acknowledge on the part of 083 and 084 our sponsors at the US NIH for 084, Bill and Melinda Gates Foundation, ViiV Healthcare for both, the HIV Prevention Trials Network, our pharmaceutical partners, our study teams, our program managers, community educators, recruiters, and CAB members, our sites and site teams, and our study participants, and of course you, our audience. Thank you very much for your attention.
So the next talk is by the person who Dr. Lenowitz just mentioned, Dr. Linda Gale Becker. Linda Gale is a director of the Desmond Tutu HIV Center at the Institute of Cape Town, where she also is a chief research officer at the Desmond Tutu Health Foundation. Linda Gale should be well known to all of you. She has been the past president of the International AIDS Society, and she has served as international co-chair of the 9th IS and of the 22nd International AIDS Conference. Linda has led numerous clinical trials, numerous studies in treatment and prevention in TB, in tuberculosis, and in HIV. And Linda Gale is going to talk to us about what is on the horizon in the PrEP arena. So Linda Gale, the floor is yours.
What is on the horizon in the PrEP arena? Well, it's a full decade ago now that we learned that antiretroviral-based pre-exposure prophylaxis provides robust protection against HIV in all populations and routes of infection. And today, just over 1 million people have accessed PrEP. Our first generation of PrEP was daily and oral, consisting of tenofovir and emtricitabine, which are nucleotide reverse transcriptase inhibitors, in a single pill when taken daily as prescribed, and when adherence is high, we know that HIV protection is also consistent and high. We knew from previous studies that where HIV makes entry via the vaginal mucosa, then daily dosing is required. In contrast, When via the anal mucosa, then less than daily dosing is required. We have also more recently seen new antiretrovirals being used. Here you see daily and on-demand oral prevention with emtricitabine combined with tenofovir alafenamide, a nucleotide reverse transcriptase inhibitor. This can also be both daily and on-demand, but with better PK, this leads to fewer side effects and less antiviral required. So oral PrEP has definitely had an impact not only on individuals, but on the epidemic at large. In major cities where a combination of both oral PrEP and antiretrovirals as required have been used, we have seen significant reductions in incidence in communities. But daily oral PrEP isn't feasible for everyone. We know that users on their PrEP use journey have found that the need for daily use can be a barrier to early use, persistence, lead to PrEP pauses, and even discontinuation. And here in this description of PrEP users' journeys, you see a number of places where the need to take oral pills has undermined adherence to PrEP and therefore protection. We know that the challenge of adherence has been a factor for a number of different populations. And here you see a number of different studies that have reported this, particularly, and the example I show here is of the SEARCH study conducted in Uganda and Kenya, particularly young men and young women finding it difficult to adhere to PrEP on a daily basis. In this study from 083, you see again that some subpopulations struggle more than others. For example, those at younger ages. And in this group of studies amongst adolescents in young MSM and young adolescents in South Africa, we see that although adherence starts reasonably well, that ability to continue adherence beyond 3 to 6 to 9 months really becomes very difficult. We also know that there's a challenge of persistence with daily oral PrEP. Although a lot of enthusiasm at the start, and this is well illustrated in a study called POWER from Africa, we see a significant fall off in PrEP usage beyond a month and certainly 3 months. And another study here from in transgender women and men who have sex with men, that up to 20% of participants were lost to follow-up or had stopped PrEP by month 6, citing in many cases negative partner reactions and stigmatizing healthcare services. Beyond the lack of persistence, I think we are also coming to understand that some of this is simply cycling on and off PrEP. So here in this study, between 37 and 62% of PrEP initiators discontinued at 6 months. This was also seen in the SEARCH study and very well described in the study by Sirota and others showing young Black MSM in the US who had a complex pattern of PrEP starting and stopping, generally driven by a dislike of taking pills, side effect intolerability, and logistics around actually accessing PrEP. So there are both pros and cons to taking daily oral pills. The ability to stop and start obviously may be an advantage. It's good that some people can use on demand and that PrEP can even be couriered. But the no's fall into the category of poor coverage due to lack of persistence and that struggle around daily adherence. Stockouts can also be a problem. So why is it that we as human beings struggle to stick to daily things? Well, motivation doesn't always translate into action, and there are behavioral biases which make it difficult for us to do things on a daily basis, particularly when we're young and busy. So overconfidence, myopia, loss aversion, status quo bias, all have been described as reasons why we may not, as humans, be able to do something on a daily basis. The solution, we think, in prevention may be less frequent and alternative dosing strategies. In other words, longer acting agents in different formulations. And that leads us to the second generation of PrEP. We learn lessons from psychiatry that both oral and long-acting injectable formulations of antipsychotics have made medications more amenable and more available to people with chronic psychiatric conditions. Here you see in this study, both adherence and persistence were improved with long-acting agents. We also learn lessons from reproductive health and the long-acting reversible contraceptives. So in this area of public health, we find that there are also adherence issues. 5% of unintended pregnancies occur amongst consistent contraceptive users, but 41% occur due to inconsistent use. And so we have seen that long-acting reversible contraceptives have become increasingly popular, particularly among younger populations. When looking at this particular study of long-acting reversible contraceptives with injectable hormonal therapy, as well in comparison with the pill, the patch, or the ring, you see again far better contraceptive success than shorter acting agents. And this was borne out even in younger populations. We conducted a study a couple of years ago now in adolescent young women, looking at a crossover study of injectables, oral contraceptives, and the NuvaRing, and asked users to think about this in the context of HIV prevention methodologies. And what you see is the reasons some people cited for not wanting to use oral contraceptive was the concern that they may not remember to take a daily pill. So that brings us to the second generation, and first in that is the vaginal ring. The dapivirine ring, it's a non-nucleoside reverse transcriptase inhibitor. It's used as a vaginal ring inserted monthly. And here you see two studies showing around about 30% vaccine efficacy in the randomized trials, but in the open label extension studies extending to a 50% efficacy. This has now been approved and is in the WHO recommendations for women in low and middle income countries as a second line to PrEP. So the topical rings again have pros and cons. We think there will be improved adherence, fewer side effects, the need potentially for fewer healthcare visits, but definitely young women, particularly in areas where vaginal products are not well known, need a period of acclimatization. We have great hope for the possibility of multi-purpose rings, but until that time, there are other considerations around sexual reproductive health that need to be borne in mind. The next wonderful discovery has occurred more recently, that being long-acting suspensions delivered via intramuscular injections. And here we consider cabotegravir long-acting. This is a strand transfer integrase inhibitor. And the two trials, HPTN 084 in young women and HPTN 083, have just finished in the last couple of years. The significant factor here is the long half-life of this intervention, with the injectable having a half-life of up to 65 days, and so requiring an injection only every 8 weeks. And certainly significant results we've seen here, most recently amongst the young women, showing a pooled HIV incidence in the whole population of just over 1 per 100 patient years, but a significant 83% reduction in HIV in women who were on the injectable arm. So without doubt, the injectables have a lot of promise. Again, the need for less frequent reminding, the ability to adhere. We do still need to understand how we will actually administer these drugs in practice. There are some considerations around the long tail. And again, we need to consider other aspects of sexual reproductive health along with this wonderful new intervention. There is another area of pre-exposure prophylaxis that is unfolding, namely that of passive immunization using broadly neutralizing antibodies. And the first agent to be investigated is this VRC01. You see that it is a CD4 binding site monoclonal antibody. We've just completed a massive study known as the antibody-mediated prevention study. And this has just recently been published. In vitro viral susceptibility to VRC01 does appear to predict prevention efficacy in vivo. However, it was only effective against viruses measured to be neutralization sensitive. So in overall data, we did not see significant difference in HIV acquisition between the arms because only 30% of circulating strains in the control group were susceptible to in vivo to the antibody, giving us a lower power to detect overall efficacy. It is important, however, to note that this is a proof of concept, and happily there are many very exciting antibodies in the pipeline that will be put together into strategies to explore this further in the next few months and years to come. Moving along, in terms of what is up ahead of us, there is this agent known as islatravir. It is a nucleoside reverse transcriptase translocation inhibitor, which has a novel mechanism of action. And this particular agent is being developed both for treatment and prevention in its first iteration as a monthly pill for HIV prevention. It's a very exciting PK, very potent, and the interim analysis suggests that monthly doses of islatravir really does achieve very promising levels, suggesting that this may be a very effective preventive intervention. It is moving forward in clinical development, and here you see 2 phase 3 trials, Empower 022 among cisgender women and Empower 024 among men and transgender women who have sex with men. These studies are just about to start, and in fact, P022 has commenced in the United States. And there you see the schema with a 1-to-1 randomization. All individuals will receive some form of PrEP, either as the monthly pill or as daily FTC TDF. And you see that it is a double-blind, double-dummy approach. Here you see the P024 study design, and this will be in a 2-to-1 randomization and will get underway a little bit later this year. Very exciting. This is being developed as a long-acting implant for HIV prevention, and we saw the first results of this, and this was further described at the most recent conferences. Moving forward, as mentioned, as an implantable, which is reversible with removal. It is certainly long-acting, hoping to be at least 6 months to a year, and has the potential for multi-purpose technology. There are other PrEP implants also underway. Here you see a TAF implant for prevention, and this was described at the recent R4P study in macaques, showing a lot of promise, and a cabotegravir reservoir implant for prevention. Again, early results shown at the R4P conference. There are long-acting injectables also coming to us in clinical trials this year. Here is lenacapavir. It is an HIV-1 capsid inhibitor and will require dosing every 6 months. So really very exciting to only have to take an injection twice a year. And here you see the PK data. The design for this is will evaluate not only lenacapavir, but also FTAF in young women who have sex with men in South Africa and other countries in Eastern and Central Africa. There are 2 primary endpoints as mentioned, lenacapavir versus background HIV and FTAF versus, again, background HIV rate. So exciting new designs and new ways forward. This will also be tested amongst cisgender men, transgender women, transgender men, and gender non-binary individuals in a number of countries later this year. And there again, you see the design for that study. So a very exciting time when we really do have an impressive lineup of not only daily, on-demand, but also long-acting PrEP agents, the less frequent and alternative dosage, opening a lot of different opportunities, hopefully improving adherence, requiring less frequent reminding, potentially fewer healthcare visits, and perhaps hope for more discretion. There is no doubt that PrEP, like so many aspects of prevention, very much depends on preference. And throughout even a single individual's life course, career changes, new relationships, travel, different PrEP options may be preferred under different circumstances. We know that humanity comes in many shapes and forms, and we believe that prevention should too. We also believe that PrEP should. And I think it's very exciting that we are at this time when we are able to offer many different forms and modalities of PrEP. This will also require many different delivery models and distribution points. And I believe the next few months to years, we will begin to really hone what PrEP differentiated service delivery really means. I think it is then that we may expect better coverage of all people and better coverage of all HIV exposures. And with that, I acknowledge a number of different people and thank you for your time.